The last topic that I would present in this series from my end would be what are the organ preservation surgeries that we have in carcinoma larynx. In a sense, what are the partial laryngectomies that are used today? What has happened is in the last few decades, with the advent of organ preservation strategies, both by non-surgical as well as transoral laser, a lot of the open partial laryngectomies have, faded away, especially the vertical partial laryngectomies. But there is still literature published now and then from the results of partial laryngectomies, especially horizontal partial laryngectomies, both in the primary setting as well as in the salvage setting. This is a very brief presentation. It's not going to be as extensive as my previous presentations. A lot of this would be pictures from textbooks, but I would try to explain to you the steps that are involved and when you would use a particular type of partial laryngectomy in a patient. So like I mentioned, in the last 2 or 3 decades, there have been significant changes in the management of carcinoma larynx. If you look at a lot of the centers in Europe, especially Italy and the surrounding centers, a lot of the T1, T2 glottic and supraglottic tumors are being treated by transoral laser microsurgery. And there are several reports, especially from Peretti's group and from Piazza's group, where they have 400, 500 patients where they have shown good local control and good survival when you compare transoral laser microsurgery with radiation treatment. Now, a lot of these transoral surgeries have uh, been evolved because of improvement in instrumentation and exposure, and hence there has been a lot of changes. And earlier in T3 larynxes, especially, uh, Lacrier's group from France and certain other centers have attempted to do procedures less than a total laryngectomy uh, as a surgical, definitive surgical procedure. It went out of vogue for some time, but then there has been a resurgence in the horizontal partial laryngectomies recently, especially in the salvage setting. So significant changes move from open procedure to endoscopic laser resection, more move towards organ preservation, chemoradiation for T3 lesions, especially of the glottis glottis supraglottis that does not involve the cartilage. And there are really fewer indications for true partial laryngectomies these days. So this is a commonly asked question in the exams. What are the principles to remember in surgical organ preservation? So if you're considering a patient for surgical organ preservation, you have to make sure that your surgical technique gives good local control and also does not impede in the follow-up of the patient. You have to embark on surgical organ preservation only after you map the tumor properly. So all of you are aware that there are three potential or three spaces of the larynx, pre-epiglottic, paraglottic, and the anterior subglottic space. And the involvement of these spaces sometimes precludes the use of a partial laryngectomy. So you've got to remember that using imaging, especially the paraglottic and the pre-epiglottic space, you have to be able to definitely prove their involvement or them being free. The subglottic extension also is important because there are different classifications given for true subglottic involvement. Any patient who has got significant subglottic involvement might have involvement of the cricoid joint. So if you have involvement of the cricoid joint, the cricoid cartilage or the cricoarytenoid joint, you may not be able to do a horizontal partial laryngectomy. So that is why you have to understand the anatomy and the need to preserve an intact cricoarytenoid unit. And in some of these partial laryngectomies, you have to remember that at no cost should you sacrifice the functional outcome. So the oncological outcome is one, the other outcome is the functional outcome. And the functional outcome should be maintained, even if it means that you resect some amount of normal tissue of the larynx. So these are the four principles that guide in partial laryngectomy procedures. So good local control with ease of follow-up. Make sure you map the patient both by imaging and endoscopy. uh, Remember the anatomy and preserve the cricoarytenoid unit. And remember that functional outcome should be preserved, even if it means that you have to resect some amount of normal tissue. So, if you look at organ preservation strategies and the surgical organ preservation, they can be divided into open, which is external, and endoscopic procedures. So, open procedures are vertical partial laryngectomies, where you divide the larynx in a vertical fashion, wherein a hemilarynx or an extended hemilarynx is removed, or it can be a horizontal partial laryngectomy where you transect the larynx at the level just above the vocal cord in a supraglottic laryngectomy, or just above the arytenoids in a supracricoid laryngectomy. The endoscopic procedures are the ones that are more commonly used, and this is the transoral laser microsurgery. And we are not going to focus too much on the non-surgical aspects in this presentation. So when you're planning for a partial laryngectomy, what are the things that you should remember? Always take an adequate history. The importance of history is that if a patient has a dysfunctional larynx, meaning that the patient has significant aspiration, not able to tolerate an oral diet, or having stridor, these are patients who don't have a functional cricoarytenoid unit. And these patients are likely to fare poorly when you attempt to do a partial laryngectomy. Always look at the functional status of the patient. The performance status is important because in the immediate postoperative period, any partial laryngectomy that you do, patients will have impaired glottic competence. It can be a vertical laryngectomy or a horizontal partial laryngectomy. They will have some impaired glottic competence. And unless the patient has a good lung function and good performance status, these patients will do poorly in the postoperative period. They are likely to be tube dependent, and these patients may require a completion laryngectomy in the long term because they're just not able to tolerate a diet, or they have problems with breathing. A laryngoscopy is mandatory because the laryngoscopy gives you an idea of some of the spaces that are involved by the tumor, especially the ventricle, the anterior commissure, and the anterior subglottic wedge. So these are important areas that have to be looked at when doing a laryngoscopy. And the last thing is imaging, which I'd mentioned, the pre-epiglottic and paraglottic spaces, because if the pre-epiglottic and paraglottic spaces are involved, you most likely will end up doing the most complete partial laryngectomy procedure, which is a supracricoid, compared to the less aggressive partial laryngectomy. So in the imaging, you have to look for the replacement of the paraglottic or the pre-epiglottic fat by tumor tissue before you plan your partial laryngectomy. So good performance status, good history taking, endoscopic mapping of the tumor, imaging mapping of the tumor, understanding the spaces that are involved. All these are important. Another thing which is not reflected on this slide is that when you do a laryngoscopy on the patients, you just don't look at the spaces that are involved or the areas that are involved. You also look at the fixation of the cricoarytenoid joint. Some patients, there are two types of vocal cord immobility. One vocal type of vocal cord immobility is immobility because of the involvement of the thyroarytenoid muscle, and the second is because of the fixation of the cricoarytenoid joint. Now, involvement of the thyroarytenoid muscle and subsequent fixation of that cord is not a contraindication to do a horizontal partial laryngectomy. But if you have involvement of the cricoarytenoid joint, meaning that the joint is immobile and it is fixed, then that is a contraindication for a horizontal partial laryngectomy. So not only do you map the tumor, you also look for the joint fixation, because that will let you know whether you have an intact cricoarytenoid joint or not. So when you look at the first type or the earliest described type of partial laryngectomy, it is the vertical partial laryngectomy. Now, the vertical partial laryngectomy is a simple procedure. In a sense, you divide the larynx vertically, meaning you do a hemilaryngectomy, you remove the vocal cord, you remove the ipsilateral thyroid cartilage, you preserve the mucosa of the pyriform sinus, and then you reconstruct the ipsilateral thyroid lamina by a variety of techniques. Now, this used to be very popular prior to the introduction of transoral laser microsurgery, because a transoral laser microsurgery, depending on the type of TLM that you do, can basically do the same surgical excision as a vertical partial laryngectomy. So if you look at the traditional indications of a vertical partial laryngectomy, it used to be T1 lesions, usually bulky lesions that are difficult to be excised with a laser, or it could be small lesions. It can be select T2 lesions of the glottis with minimal supraglottic and subglottic extension. But most importantly, if you're planning for a resection of a T1 glottic tumor and the patient has poor mouth opening, bad teeth, inadequate exposure of the larynx, any of the contraindications for a transoral laser microsurgery, these would be patients that are probable candidates for a vertical partial laryngectomy. Now, there are various types of vertical partial laryngectomies. There can be a hemilaryngectomy where you remove the involved cord, the ipsilateral thyroid cartilage, you preserve the contralateral cord, you preserve both arytenoids. There can be a frontal hemilaryngectomy where you remove the anterior edges of the two vocal cords with the associated thyroid cartilage and anterior commissure. There can be a frontolateral where your excision extends to the contralateral cord and the contralateral thyroid lamina, or there can be an extended hemilaryngectomy. But these are all seldom practiced today. If at all, for exams, or if you're asked questions, or if you want to conceptualize what a hemilaryngectomy should be, these are the different types of vertical partial larynxes that we can excise. Now, I try to tell you the most simple form of the vertical partial laryngectomy, where you're removing just the ipsilateral vocal cord and the associated thyroid cartilage. These are pictures from Eugene Myers' textbook. What you do is you make a neck incision, you raise a subplatysmal flap, and then you retract the strap muscles and expose the thyroid cartilage. So this is the notch of the thyroid cartilage. This is the inferior border. This is the cricothyroid membrane. Once you expose the thyroid cartilage, you elevate the perichondrium of the thyroid cartilage and make it free of the perichondrium. Once this is done, depending upon the calcification of the thyroid cartilage, in young people, the cartilage is not calcified, so you might be able to use a large knife to cut through it. Otherwise, you might need a sagittal saw. You cut through the thyroid cartilage, just to expose the contents of the endolarynx. So this cut conceptually is in the thyroid cartilage in the midline or just across the midline if the tumor extends to the opposite side. The soft tissue cut is through the cricothyroid membrane and above in the thyrohyoid membrane. Once this cut is made, the larynx opens up. You use two skin hooks or double hooks, and you retract, exposing the contents of the endolarynx. Once the contents of the endolarynx is exposed, you will be able to see the arytenoid with its vocal process, the ventricle, and the tumor involving the true cord. And once this is done, all we need to do is use the scissors and then give adequate margins and cut through the posterior aspect of the thyroid cartilage, just behind the thyroid cartilage, preserving the piriform mucosa all the way to the superior cornua of the thyroid cartilage. So once this is done, all you will have is the intact vocal cord. You will have an intact thyroid cartilage. You have to suture the intact vocal cord to the thyroid perichondrium and the thyroid cartilage to give it some tension. Otherwise, the patient's voice will be worse. This helps to keep the vocal cord taut. And the most important aspect here is you can advance the piriform sinus mucosa on the resected side anteriorly by a few loose sutures to fill up the posterior glottic space. Now, the question is you will have an open larynx as seen in this image. There are a variety of techniques that have been described to reconstruct the thyroid skeleton, the thyroid cartilage skeleton following a vertical partial laryngectomy. People have used free flaps. For example, Ralph Gilbert from Canada has used a temporoparietal facial free flap along with cartilage and mucosal grafts. People have used the adjacent strap muscles to cover the defect. People have done a lot of things. There have been several techniques that have been described, but probably the easiest technique is to use the epiglottis to resurface the defect. Now, what you do is you do a subperichondrial dissection on the surface of the epiglottis, grasp it with an Alice forceps. You will be able to see the epiglottis through this wound. Grasp it with an Alice forceps as you see in the figure C. Bring it to the defect and suture it all the way around in the anterior defect of the larynx. Now, as I mentioned, there are various types of reconstruction that have been described. Temporoparietal free flap with mucosal and cartilaginous graft by Gilbert. There's the platysma myofascial graft, which has been described by Durson. There's a sternohyoid myofascial graft described by Yagudin. But the problem with all of the types of reconstruction is that vertical partial laryngectomy, whatever reconstruction you do, there are problems with laryngeal stenosis. So you've got to remember that, and probably the epiglottic technique is most suited to prevent laryngeal stenosis, probably the least rates of laryngeal stenosis. And because of the escape of air from the cut ends of the thyroid cartilage, patients tend to develop subcutaneous emphysema. And the voice isn't great because you don't really have a new chord on the other side. You don't have a template for the pseudo chord to develop on the opposite side. So the voice outcomes aren't really great with the vertical partial laryngectomy. And I guess that is one of the reasons why this has sort of moved back, and people have started doing more endoscopic procedures. And bear in mind, T1, T2 glottis without supraglottic or subglottic extension with radiation treatment, we are looking at laryngeal preservation rates above 95%, and we're looking at 5-year overall survival above 90%. So there is no, path-breaking advantage that an open procedure would allow you. An endoscopic partial laryngectomy for a T1 glottis has the advantage that you reserve the radiation for later, and it also has been found that chances of laryngeal preservation are higher in T1, T2 glottis following a laser resection compared to radiation, because 70% of patients who have radiation failure with T1, T2 glottis end up with a total laryngectomy, whereas patients who fail a prior endoscopic laser partial cordectomy can always be subjected to another laser procedure or radiation. So vertical partial laryngectomy really does not fill any of those blanks, and I guess that is the reason why the procedure isn't done as much as it was done before. The thing that is most interesting and intriguing is how there has been a persistence in performing horizontal partial laryngectomies. Now, if you want to classify horizontal partial laryngectomies, there are different levels of the larynx that you can transect, different types of reconstruction that you can do, and they are for different indications. And the European Laryngological Society, headed by Succo from Italy, have proposed a nomenclature or a classification for a horizontal laryngectomy. And the basic premise of this horizontal laryngectomy, the explanation is quite simple. If you look at type 1, it is a supraglottic laryngectomy, wherein the arytenoids and the vocal cords are preserved and everything above that is resected. A type 2 is a supracricoid laryngectomy, wherein you preserve the cricoid cartilage and at least one functional cricoarytenoid joint and resect everything above that. And type 3 is supratracheal laryngectomy. You have additional resections, so you can add an arytenoid resection, you can add a base of tongue resection, you can add a piriform sinus resection, or you can add a cricoarytenoid joint resection. And it probably will help us for data collection and to look at the individual outcomes of the patients. But probably is most commonly done is a supracricoid and maybe supraglottic laryngectomy after that. So the supraglottic laryngectomy because it is oncologically safe. It preserves the vocal cords and the arytenoids so that your glottic competence and voice is normal. The postoperative stay and rehabilitation is short, and your oncological outcomes are quite good. But the problems with the supraglottic laryngectomy is that all of you are aware that supraglottic tumors have a very high incidence of occult nodal metastasis. So, unless you treat the neck along with a supraglottic tumor, you're not completing the treatment. And if the patient ends up with a positive node, the patient will not be able to complete the treatment. But yet, there are some patients who don't want radiation, who are node negative after extensive neck cancer, and in these patients with a small supraglottic tumor, I still think a supraglottic laryngectomy has a role. So it is good for T1, T2 supraglottic tumors, and it involves removing the false cord, the epiglottis, the pre-epiglottic space, upper half of the thyroid cartilage, eriepiglottic fold, with or without the removal of the hyoid bone. If the hyoid bone is involved, or if there is margin to be taken at the hyoid, you remove it. Otherwise, you preserve it to facilitate reconstruction. When don't you do a supraglottic partial laryngectomy? Obviously, when the tumor is T4, when there is involvement of the thyroid cartilage, obviously, when there is fixity of the cord, which makes it T3, when there is extensive tongue base involvement, meaning that your reconstruction is going to be difficult and you cannot impact the residual larynx to the base of tongue. And when there is ventricular involvement, meaning your Your plane for margin should be the positions for a supraglottic laryngectomy. I urge all of you to read Tufano's Ology. Very few textbooks mention the actual technique of doing supraglottic and suprachiasmatic so eloquently as Tufano and Sewell's article. So basically, what you do is you make a neck incision make a neck incision in the thyroid cartilage. You divide the strap muscles in a way that there is only a small stump at the hyoid bone, and the rest of the strap muscles are reflected inferiorly. Once this is done, you incise the perichondrium of the thyroid cartilage and reflect that inferiorly also. You divide the constrictor muscles along the body and the greater cornu of the thyroid cartilage. And I mentioned to you that what we remove in a supraglottic laryngectomy is all the structures above the glottis, that is the true vocal cord. Usually, this plane externally is identified by the midpoint between the thyroid notch and the inferior border of the thyroid cartilage. So you mark that point and stay 1 millimeter above that. And you make oblique cuts on the thyroid cartilage with a sagittal saw or a reciprocating saw. So once you do that, then you enter into the pharynx just below the hyoid bone. And once you do that, like a normal laryngectomy, you will be able to see the epiglottis, and you move to the head end of the patient and you grasp the epiglottis with an Alice forceps. Once you grasp the epiglottis with an Alice forceps, your aim is to divide the aryepiglottic fold, preserving the arytenoid, its vocal process, and the remnant glottis. So you make horizontal transecting incisions as shown in this last picture here. Here you can see the epiglottis being held by an Alice forceps and tumor here in the epiglottis. And you can see the direction of the scissors is such that you are staying above the plane of the glottis and preserving the arytenoid cartilages and cutting out the upper third of the thyroid cartilage. So once that is done, what you're going to have is the reflected strap muscle, the reflected perichondrium, and the remnant thyroid cartilage with the arytenoid and the true vocal cords. Now, the true vocal cords have to be sutured to the perichondrium by loose sutures to maintain their tautness, but I usually don't do that. It's not a compulsory procedure that you do. But if you do that, you will be able to maintain tautness of the true vocal cords. But the principle here is that you're trying to move the remnant thyroid cartilage towards the hyoid bone. And you can do tracheal mediastinal release by using finger dissection. In most cases, you would need to divide the isthmus of the thyroid gland to create space for cervicomedial mediastinal blunt dissection to mobilize the trachea and the remnant thyroid cartilage. Using a series of sutures which encircle the hyoid bone and the thyroid cartilage, you first pass the sutures and then tie them sequentially so that the remnant thyroid cartilage impacts with the hyoid bone. So in the end, you will have a picture like this, where your suture passes from the thyroid cartilage and goes towards the base of tongue and the hyoid bone by encircling it, and then you tie the suture. So you're basically impacting the remnant thyroid cartilage with the hyoid bone. Now, these patients do quite well because they have intact glottic competence. Their voice isn't affected that much. But in most of these cases, we will end up doing a bilateral neck dissection because, as I had mentioned, the chances of occult nodal metastasis is quite high. So, in young patients, in patients who particularly do not want radiation treatment, this might be a good choice for an operation. And as I had mentioned, you're removing the entire preepiglottic space, so there is tumor involvement there. you're having oncological clearance, and it is well suited for T1, T2 supraglottic tumors. Now, the last horizontal partial laryngectomy that is probably the most interesting and most important is the supracricoid partial laryngectomy. So the question is, why is there a persistent interest in supracricoid partial laryngectomy? The procedure was described a long time ago. There have been many modifications and many additions to the technique, but the basic principle or the most important point is that a supracricoid partial laryngectomy acts as a bridge procedure between other open partial laryngectomies and a total laryngectomy. Meaning, in patients who are candidates for total laryngectomy, but who satisfy certain prerequisites, they can be eligible for a supracricoid partial laryngectomy. The advantages of supracricoid partial laryngectomy are obvious. In a total laryngectomy, you know that the patient lives with a lifelong stoma, and unless you rehabilitate the voice with a prosthesis or esophageal space, you're aphonic. Whereas in a supracricoid partial laryngectomy, there is no stoma. The patient might have a breathy voice, but he is free from using a prosthesis or an esophageal speech. And time and again, with a lot of evidence, we have found out that this is a suitable procedure both in a primary as well as in a salvage setting. Usually, in a salvage setting, if you try to preserve any part of the thyroid cartilage post radiation, especially if it's chemoradiation, that part of the thyroid cartilage, because of the chemoradiation and the surgical trauma, can go into chondronecrosis. Whereas in a supracricoid partial laryngectomy, we remove the entire thyroid cartilage. So, time and again, primary and in the salvage setting, a supracricoid partial laryngectomy has been found to be safe from chondronecrosis and a functional point of view. Oncologically, the results have been very encouraging, especially in the salvage setting, through many large series and systematic reviews and meta-analysis. You avoid a permanent tracheostoma, as I mentioned, and the patient has acceptable voice and has oral intake. So, if you look at one of the good papers published in JAMA many years ago in 2005, the 3, 5, and 10-year survivals are still brilliant in patients who have supracricoid partial laryngectomies. They're close to 80%, 85% for 3 years, 80% for 5 years, and 57 10-year survival. And it's very important that when you do a supracricoid partial laryngectomy, that you make sure your margins are clear and there are no dysplasia at the margin. So try to use frozen section control as much as possible, because analysis of prognostic factors has shown that these are the important things that affect outcome. And if you look at radio recurrent tumors, the systematic review and meta-analysis of literature showed that in a radio recurrent tumor, you have 85% laryngeal preservation rate, a decannulation rate of 92%, and 96% swallowing recovery, and very small percentage of PEG dependence and aspiration pneumonia. Now, all this has to be taken with a pinch of salt because it depends upon the patient's pre-surgical morbidity. If the patient has a dysfunctional larynx or aspiration or breathing problems, they're likely to do badly with a supracricoid partial laryngectomy. If the patient is a chronic smoker who has a bad lung, they're likely to do badly with a supracricoid partial laryngectomy. If the patient is old, they're likely to do badly with a supracricoid partial laryngectomy. So case selection is important, especially with reference to pre-surgical morbidity and other associated factors. Now, as I had mentioned, amongst all of the partial laryngectomies, a supracricoid partial laryngectomy offers the most comprehensive resection. The reason being, you resect the thyroid cartilage, you resect the false vocal cords, the paraglottic space. If there is an arytenoid that is involved, you remove the arytenoid. You remove the pre-epiglottic space if it's involved, and if the epiglottis is involved, you remove it. Otherwise, you can preserve the epiglottis for your impaction. So this is the most comprehensive resection that you can attain in any partial laryngectomy. But the important thing is you have to preserve at least one cricoarytenoid unit. Remember, after removing all of these structures, you still have to be able to maintain glottic competence, meaning the patient should not aspirate and die because of the aspiration. And because of the movement of at least one functional joint, they should be able to have meaningful speech. So the cricoarytenoid unit is the most important thing that you have to remember. It is a complex unit described by the cartilage, which is the cricoid cartilage, and the arytenoids. The muscles are the posterior cricoarytenoid, lateral cricoarytenoid, and the interarytenoid. And you need to preserve the nerve, the recurrent nerve, and the superior laryngeal nerve. So at least one cricoarytenoid joint or cricoarytenoid unit has to be preserved if you want to have a meaningful recovery after supracricoid. If both the cricoarytenoid joints are involved, the patient needs a total laryngectomy. So when do you do a supracricoid partial laryngectomy? Again, it is a T2 to T3 supraglottic tumor or a glottic tumor if the conditions are met, meaning you can still do it for a T4 glottic tumor with minimal pericondyal involvement, or you can do it when the cricoarytenoid joint is free, at least one cricoarytenoid joint is free. But probably in today's context, it is good for salvage surgery after failures of T1, T2 supraglottic or T1, T2 glottic tumors not involving the cricoarytenoid joint. When can't you do a supracricoid partial laryngectomy? Obviously, when there is interarytenoid involvement, meaning you cannot preserve one cricoarytenoid unit, when there is bilateral arytenoid mucosal involvement, if there's bilateral arytenoid fixity, when there is subglottic extension, meaning that the cricoid cartilage has to be excised, when there is gross preepiglottic involvement, and when there is involvement of the hyoid bone. These are some of the contraindications for a supracricoid partial laryngectomy. This is an article by Duane Sowell, again, very clearly explaining the steps of a supracricoid partial laryngectomy. Both these articles, Tufano and Sewell, I recommend strongly that everyone reads. Sewell describes the hyopexy, not the hyoepiglottopexy, but the basic surgical steps are the same. I will show you a video after this slide regarding the steps of a supracricoid partial laryngectomy. Basically, you make a neck incision, subplatysmal flaps. You divide the strap muscles close to the hyoid bone, reflect them inferiorly. Uh, you divide the constrictor muscles and reflect the pyriform sinus mucosa as you would do for a normal laryngectomy. Remember here, in this operation, you are trying to preserve the cricoarytenoid joint, meaning that this is the space above the cricoid cartilage. You have to be careful. So using a Freya's elevator, you disarticulate the inferior corner from the cricoarytenoid joint, preserving the cricoarytenoid joint in its entirety. So this is done bluntly so that the lateral border of the thyroid cartilage completely is exposed. Then you do the entry into the pharynx by dividing the soft tissue just below the hyoid bone. The rest of the steps are the same. You grasp the epiglottis with an analysis forceps. This is just like supraglottic laryngectomy, but the difference here is that you are going via the cricothyroid membrane and just below the thyroid cartilage. So here you orient your scissors in such a way that it's with part of the vocal process that is preserved. and then you use your scissors. The way you get this exposure is once you hold the epiglottis with your Alice forceps, using your fingers, you have to fracture the thyroid cartilage and open it like a book, and you will get this cartilage called external arytenoid cartilage. Otherwise, bilateral arytenoid cartilages can be preserved. And just like in supraglottic laryngectomy, you have to do impaction in a supracricoid laryngectomy as well.
Deepak sir,
So one of the things, hello,
hello. Sir, there is a small technical lag and the voice has broken from the beginning of this procedure. Can you just re-explain it?
the supracricoid.
Yes, sir. From this procedure.
Yeah. So in supracricoid laryngectomy, what you do is you make a transverse neck incision and you raise a subplatysmal flap to expose the underlying neck. Then you incise the strap muscles close to the hyoid and reflect the rest of the strap muscles inferiorly. Once you reflect the strap muscles, you have to divide the constrictors at the lateral border of the thyroid cartilage, and by subperichondral dissection preserve the piriform sinus mucosa. Once you come to the inferior cornua, using a Freer's elevator, you have to dislocate the inferior cornua from the cricoarytenoid articulation because you have to preserve the cricoarytenoid joint. Once the disarticulation is completed, you can enter into the pharynx as you would do in a normal patient. And once you enter into the pharynx, you would grasp the epiglottis with an Alice forceps. Once you grasp the epiglottis with an Alice forceps, you can outfracture the thyroid lamina with your fingers like a book, and it would give you an exposure like this. And then using a scissors, just like in supraglottic laryngectomy, but slightly differently here, you transect the larynx in such a way that you include the true vocal cords and part of the immediate subglottis in your resection specimen, and only preserving the arytenoid cartilages and the vocal process. Once you do that, this is how your field would look like: an intact cricoid ring, two arytenoid cartilages on top, with part of your vocal process. Uh, you will have to impact the cricoid cartilage to the hyoid bone. Before you do that, you'll have to resuspend the arytenoid cartilage, otherwise they will prolapse into the airway. So you will have to take a prolapse posterior. So you will have to take loose sutures from the arytenoid cartilage to the tracheal ring or the thyroid cartilage to keep them in place. And just like in a supraglottic laryngectomy, you take encircling stitches from the cricoid cartilage and the hyoid bone and tie them sequentially so that the cricoid cartilage, the arytenoid cartilage impacts the hyoid bone superiorly. So this picture shows a case where the epiglottis has been taken completely. But you can also transect this specimen by leaving part of the epiglottis on the patient, and this would be an impaction called the cricohyoepiglottopexy and not a cricohyopexy. This picture is a cricohyopexy, but if you retain part of the epiglottis, it is called a cricohyoepiglottopexy. So I will just show you a video of the supracricoid partial laryngectomy with a CHEP. Can you hear me now?
Yes, sir. You're audible.
Yeah. So this is a video of a supracricoid partial laryngectomy. So you make a transverse neck incision or a U-shaped neck incision slightly higher up because you'll have to take into account doing tracheostomy also below, and you don't want the tracheostomy to communicate with your supracricoid laryngectomy that you have done. Once you do that, you raise a subplatysmal flap. Once the subplatysmal flap is raised, you have to start skeletonizing the larynx. And this is done by separating the sternocleidomastoid muscle from its proximity to the thyroid cartilage. So all this can be done with a diathermy. So once the sternocleidomastoid muscle has been separated, we transect the strap muscles close to the hyoid and reflect them inferiorly. And using stay sutures, we can keep them in place. Now, the reason why these strap muscles are transected, is the video visible now?
Yes, sir. The video is visible now. And your audio is also clear.
Yeah. So once the thyroid cartilage is visualized, then we incise the constrictor muscles on the lateral aspect of the thyroid cartilage. So using a double skin hook, you can retract the lateral border of the thyroid cartilage, and you can divide the constrictor muscles, the inferior constrictor. And this is what is being done now in the video. And once the inferior constrictor has been divided, we use a phrase elevated Now, one of the important things that you have to remember is that it's always good to divide the isthmus and then separate the two lobes so that you can do cervical So this is the constrictor on the other side, that's on the left side, which we are mobilizing to reflect it off the lateral border of the thyroid cartilage. And you again do the subperichondrial dissection of the piriform sinus mucosa and the disarticulation between the inferior cornua and the cricoarachnoid joint. Now, the next step here is to identify the cricothyroid membrane. The reason being our resection is going to be above the cricoid cartilage. And at this point in the operation, we need to transfer the endotracheal tube through the cricoarachnoid membrane into the trachea. So this is opening the cricothyroid membrane. You can see the endotracheal tube inside. One of the steps that I haven't shown here is that you have to divide the thyroid isthmus and use finger dissection to mobilize the trachea so that the cricoid cartilage moves up with the impaction. So once the tube has been put on the cricothyroid membrane, you try to enter the pharynx like you would do in a normal laryngectomy. In this patient, I had planned to transect the epiglottis because there was no pre-epiglottic space involvement, nor was the epiglottis involved. So this is incision just below the hyoid bone, and we are trying to enter the pharynx here. And as we go on with the dissection, you would be able to see the epiglottis come into view. And part of the epiglottis will be transected. So the superior part of the epiglottis will remain attached in the patient. This is the epiglottis being transected. Once the epiglottis is transected, we have a view into the endolarynx. So as I mentioned, once you have the epiglottis in view and you're holding the epiglottis with a Alice forceps, you have to use your scissors to make the cuts on the endolarynx. So this is the cut made on the endolarynx here to only preserve the So preserve the arytenoid and the vocal process, cut the aryepiglottic fold first, cut the false cords, cut the true cords, and preserve the arytenoid cartilage along with the vocal process. Now this is outfracturing of the cartilage as I mentioned. So once the cartilage has been outfractured, you can complete the cuts below the thyroid cartilage. So this is the scissors anterior to the arytenoids. You can see the arytenoids on both sides here. And that is the glottic inlet. This is further outfracturing of the thyroid cartilage. Again, you can see the arytenoids here. We are cutting the aryepiglottic fold on the left side. All this has to be done with scissors and not diathermy because diathermy may cause impaired healing and more loss of mucosa during the closure. So once the specimen has been taken out, what you would see here is the endotracheal tube through the cricothyroid membrane. You would see the two arytenoid cartilages. As I mentioned to you before, you take a bite through the vocal process in a loose fashion to the tracheal cartilage so that they don't prolapse posteriorly. These are loose sutures, they're not tight. Now the patient is going to phonate with the vibratory movement across the arytenoid cartilage and not across the vocal cord. Then you would have to make your impaction sutures by taking stitches through the cricoid cartilage and around the hyoid bone. In our patient, we had part of the epiglottis intact, so it was a hyoepiglottopexy. Sometimes these sutures might cut through. You'll have to suture them sequentially. You'll have to put the sutures first, but then tie them sequentially. So here, one of the sutures had cut through. All you have to do is to take a deeper bite. So basically, you're bringing the cricoid cartilage, the epiglottis, and the hyoid bone together. So this is how the pexy would look in the end. This is the epiglottis here. The arytenoids are buried inside, and this is the cricoid cartilage that you can visualize here. So once that is done, you can use the strap muscles that you have reflected inferiorly as a buttressing layer above the pexy. And this helps us to reinforce the pexy that we have done. So as I mentioned, I haven't shown you the transaction of the thyroid isthmus and mobilization of the trachea. That might be necessary for us to move the cricoid cartilage and the remnants superiorly to impact with the hyoid bone. So once this is done, you place the sutures. Patient can be decannulated 4 or 5 days later. And then intense swallowing rehabilitation is started so that the patient is decannulated from the feeding tube as well. So like I'd mentioned, this was a short presentation just to show you what is the current spectrum of partial laryngectomies that we do. And horizontal partial laryngectomies have a promising role in the management of carcinoma larynx. Tumor mapping is the key in cases where you're considering doing a partial laryngectomy. Salvage surgeries don't necessarily have to be a total laryngectomy. If you can preserve an intact cricoarytenoid joint and there is no subglottic extension, and if the patient's performance status is adequate, supracricoid partial laryngectomy can give you a stoma-free patient with good local control. Swallowing rehabilitation is necessary in cases of patients with supracricoid partial laryngectomy. And contrary to popular belief, partial laryngectomies are easy to perform and not very difficult. Any questions? I'd be happy to take them now.
Thank you, sir. Thank you for the presentation. There are a couple of questions.
Yeah.
What is the indication and procedure to do near total laryngectomy?
See, near total laryngectomy is not technically a partial laryngectomy because patient ends up with a stoma. So that is the reason why I haven't included a near total laryngectomy in the presentation. But most of the facts of supracricoid partial laryngectomy holds good for a near total laryngectomy also. You should have an intact cricoarytenoid unit so that there is a myomucosal shunt. There should not be cross subglottic extension. So the basic premises still hold for a near total. But it's not a partial laryngectomy because the patients have a stoma in the end compared to other partial laryngectomies where there is no stoma.
Sir. So our next question is by Dr. Mona Mukherjee. Is it essential to preserve hyoid? I think she's asking during when you were explaining CHEP.
Yes, if the hyoid is involved, we can't do a supracricoid partial laryngectomy.
Okay, sir. Other question is, what kind of sutures are used to suspend the vocal cords and the sutures used for hyoepiglottopexy?
Hyoepiglottopexy, you can use nylon or proline. You can use zero or any sturdy nylon, thick nylon or thick proline, because otherwise they will break. So zero nylon or two you can use, 2O nylon you can use, or 2O proline you can. Any monofilament stout sutures are fine. Whereas to resuspend the arytenoid, you can use 4O vicryl loose sutures to the trachea.
Okay, sir. Next question is by Dr. Chaudhary Satyanarayana. What is the arytenoid suture to trachea? Where is the arytenoid sutures to trachea?
The vocal process is sutured to the tracheal mucosa or tracheal perichondrium. It is just to prevent the posterior prolapse of the arytenoid. Because basically the arytenoid is not held in place by the vocal cords anymore in a supracricoid laryngectomy, so they can prolapse. So this is just a loose suture to keep it in place. So take it through the vocal process to the outer surface of the trachea or the cricoid cartilage.
Okay, sir. Next question by Dr. Komal Lamba.
Hmm.
If there is a minimal cartilage erosion through the outer cortex, can SCPL be done?
That doesn't qualify as minimal erosion. Minimal erosion is always through the inner cortex only. So if it's outer cortex, it is through and through, which makes it T4, and you can only do a total laryngectomy. People who do SCPL for T4 are the ones who do it for minimal inner perichondrial involvement. So you cannot do it for a cartilage erosion or through and through erosion.
Okay. Next question is, if epiglottis is partially preserved, is it functionally still preserved or is it just anatomical preservation?
Yes, it's anatomical, because uh, normally the epiglottis is a static structure because of the movement of the larynx. The larynx will oppose with the epiglottis whenever you swallow. There is no muscle acting on the epiglottis like that. So the same holds good even if you transect it half. It is just anatomically there, and it just gives another tough tissue for you to take your bites for your pexy. It doesn't really add much. I don't think it adds much to the functional or improved outcomes or anything like that.
Okay, sir. Sir, in continuation with the earlier question about the minimal cartilage erosion,
Hmm.
she was asking what if a cuff of straps are preserved? Cuff of strap is taken.
I don't think that's an answer that people would accept, because conventional teaching is that if you have a through and through cartilage erosion of the outer cortex is involved, patient needs a total laryngectomy. I don't, I really don't know the answer, but if you look at textbooks and literature, no one mentions in the same breath that for a T4 larynx you can do a supracricoid. Nobody talks like that. The only T4 that they say that a supracricoid can be tried if there is only minimal inner perichondrial involvement. So I don't think it's an answer that has been addressed by big series of patients or studies. I don't think it should be done from the evidence that we have and what we've been taught.
Okay, sir. So next question is, why is gross or bulky preepiglottic space involvement a contraindication for SCPL?
Sorry, why is
A gross or a bulky preepiglottic space involvement a
because
contra?
your next margin is the hyoid. Because if you have a lot, the one of the boundaries of the preepiglottic space is the hyoepiglottic ligament. So the problem is you might have to take the hyoid as a margin. So when the hyoid becomes a margin, you cannot do a supracricoid partial laryngectomy. That
Okay,
is the
sir.
problem.
Okay. One question by Amar Ahmed. Can you please explain the most updated TNM of laryngeal CA? Also, there is another American classification for laryngeal CA.
Uh,
If you can
I
put
would
it in the
suggest you,
highlights.
I would suggest you look up in a textbook. The staging hasn't changed. It's been the same.
Yeah.
But there has been a lot of push by the European Laryngological Society to reclassify CA larynx into anterior tumors of the paraglottis, posterior tumors of the paraglottis. There's a lot of push in that. That is a separate discussion altogether. So the current TNM still stays. I'm not aware of any new TNM by American Society and all that, but I know that there is a push to reclassify or subclassify based on anterior paraglottic and posterior paraglottic extension of tumors.
Okay, sir. So next question is post reconstruction of partial laryngectomy, do you place any tube to keep it patent? If so, for how many days?
So the only thing that we place the keel for is when you do a vertical partial laryngectomy, I think, to prevent glottic stenosis. I don't have any experience with it because I've hardly seen few vertical partial laryngectomies. But I guess I really don't know the answer. Maybe 2 months to 3 months, and then once the pseudocord is formed and the glottic inlet has opened up sufficiently, you can remove it. But normally for a supracricoid or a supraglottic, you don't place a laryngeal keel. It's only when you are anticipating glottic stenosis because you're doing only a soft tissue reconstruction of the resected thyroid cartilage in a vertical partial laryngectomy. Only in those cases you might think of keeping something to keep the cords, the glottis apart. Like I said, we hardly do that procedure, so not much of idea in that.
Okay, sir. So next question is little relevant for the youngsters. Is there any survivable difference between total laryngectomy and partial laryngectomy? Is there any study for it?
No, head-to-head comparison, no.
Okay. Next question is by Mona Mukherjee again. Sacrificing the body of hyoid will ensure total clearance of PEGS. So does it make any sense?
But your impaction is a problem. In a supracricoid, you need to have two bony surfaces to impact. Only then you can bring the cricoid to some meaningful level superiorly. So that's not how it has been described. Maybe partially in the lateral part of the hyoid, you can resect if there is tumor there, but you need to have an intact hyoid to be able to do a good hyopexy. It doesn't really make sense.
Okay, sir. Last question is any minimal margin required for partial laryngectomy, like 5 mm or the regular 1 centimeter?
No, see the if you look asking me for studies for a partial laryngectomy, I don't think we should deviate from the studies that have been described for any margin. So 5 mm mucosal margin is the minimum margin that you expect, which is 1 to 1.5 centimeter gross margin. So you need to have at least 5 mm. That is 5 mm in a partial laryngectomy. In an endoscopic procedure, the margins are slightly different. They are not the same. So I would say for 5 mm, definitely for partial laryngectomy.
Okay, sir. So as of now, those are all the questions in the chat box.
Yeah.
So thank you, sir. Thank you again for your lecture for us.
Thank you so much, Bhargav. And thank you all for your attention. It was a short presentation, but it is just something to stimulate your thinking for partial laryngectomy. Please read Tufano's and Sewell's article. They are really good because they show you step by step, because not many books have explained the procedure in so much detail. It is very difficult to find it. And Biller's earlier book on surgeries of the larynx had it, but they are quite confusing. These two articles are very good for learning supraglottic and supracricoid partial laryngectomy. I learned it from these two articles only.
Okay, sir. Thank you, sir.
Thank you, Bhargav. Thank you so much.